All right, so, the first semester we go through positioning, basic positioning. And we're going to review all of that this semester, positioning for everything that we're going to cover this semester. We're going to talk about the textbook positioning out of Merrill's, but then we're going to dial in what it is that you have to do in order to correct for your image. If you have to go back in and take a repeat. And last semester was all about technique, so looking at your S number, index number, and kind of evaluating that and determining what you needed to do to correct for that. And this semester is all about positioning. So that's where we are in this semester. We're going to talk about the patient's rotated, how to determine which way to rotate the patient, because the last thing that you want to do is walk back into the room and do the exact same thing that you just did. Now, I use this illustration, it's a little bit embarrassing, but it's, part of my training. I was a first semester student and they, this was a long time ago, right? It's been a minute. And, they weren't real good about following the JCERT rules at the time. So me and another early first semester student went in and did a PA and lateral chest X-ray. Lateral came out. Like, something's not right with that image, something ain't right. I don't know what it is, but we didn't get right. So we're going to go back in and we did exactly the same thing again. And guess what we got?
Same.
Exactly the same image. And what we forgot to do was elevate the arms. That's the embarrassing part, right? So we shot this lateral chest X-ray 3 times, because twice we forgot to elevate the arms. So you got to be able to look at your image and determine what's the matter with the image, not just, that doesn't look good, I'm going to go redo it. What'd you do wrong, right? What'd you do wrong so that you can do it right the next time? We're going to start with chest. We're going to follow pretty much the same outline as what we did in first semester positioning, and we probably won't get to a test on spines, but we'll do chest and abdomen, upper extremity, lower extremity, and we'll get into spines. But we probably won't have a test over spines. It'll be on the final, but we won't have a test over. So, chest and abdomen. So your textbook Merrill's positioning is placed top of the collimated field, and we used to say the image receptor, but that's not quite adequate anymore. We're not going to get all the way through chest and abdomen today, and I've saved some images that I've pulled from some Facebook groups that really embarrass me as far as the profession goes and the lack of collimation that's going on. There was one is pediatric chest X-ray that included almost the entire abdomen, but it was chest X-ray. So, you place the top of the collimated field, and understanding the patient's anatomy is very important in this. Put the top of the collimated field about 1.5 inches above the shoulders. We talked about this in the first semester, and it's important to understand what part of the shoulders and how the patient needs to be standing posture-wise in front of that collimated field. So some of your patients walk around with shoulders elevated all the time, and the demographic most of the time here is small men, right? I don't know if it's some subconscious thing to make them look a little more puffed up, but you got these little big guys that walk around with shoulders up, and the problem is that you put the top of the top of the collimated field 1.5 inches above the shoulders as the outer portion of the shoulders, not the inner portion. Top of the collimated field 1.5 inches above the outer shoulders, but if the shoulder's up like that, you're getting earlobes, right? So you don't need that. So you make sure that the shoulders are relaxed, and then you put the top of the collimated field 1.5 inches above the relaxed shoulders. What you'll see in other textbooks is that if you put your pinky finger on the vertebral prominence, that's a knot on the back of your neck, and you extend your thumb down the patient's back, that's kind of get you roughly to T7. Well, the problem with that is that, like my daughter has these hands that stopped growing when she was about 4 months old. I mean, she's got tiny little bitty hands, right? So, mine's like this, hers would extend to about here, right? So not real accurate. It gets you in the general vicinity, but not real accurate. So, you know, the textbook positioning, inch and a half above or below, above the relaxed shoulders is good. Centered T7, which is the bottom of the scapula, right? Now you can't really see exactly where the bottom of the scapula is unless the patient's very, very small, but you have to have that, you know, in mind for the registry. So centered T7, all your chest x-rays with the exception of the lordotic is going to be position T7, so you just file that away, T7. Second inspiration, how many of y'all are actually still doing second inspiration, or the techs you're working with actually doing second inspiration? Yeah, not many, not many. Does it make, what's that?
1 for every 10.
1 for every 10. So does it make that much of a difference? You know, I don't know. Probably it makes a little bit of a difference. But remember, that's testable. So when you get to the registry, it's 2 deep inspiration. And a change in Merrill's, and Merrill's is going to be your main guidebook for the registry. That's why we use it. Bontrager's as well, but I'd say Merrill's probably more so than Bontrager's. But Merrill's, honestly, I don't remember exactly where the change occurred, but at some point they started specifying on the lateral to take 2 deep inspirations as well. It used to be 1, now it's 2 on both. Okay, so second deep inspiration. Look for your artifacts. Bras, necklaces, tubes, wires, buttons, snaps, safety pins. All right. And this is probably the one that's caught me more than anything else, is safety pin. You get a little old woman that comes from home in her nightgown, she's got a safety pin in there. And she will argue with you till she's blue in the face that she does not have a safety pin. And you finally trust her, and you take the image, and guess what she's got? A safety pin. So you spin the monitor around. Look! Oh, honey, I forgot I had it. I knew you had it. I don't know you, but I knew you had it. All right, so look for all that stuff. And you can do some of this without even asking, you know, because some of your patients lie to you. You have bra on? Yeah. No or no. And, you know, while you're positioning, you just feel for bra straps. You've got a bra on. Bra's got to come on. So you frisk them, you look, you ask, all that stuff. So some of the wires and the tubes, there are better preferred places to put those. You know, if a patient has a NG tube, put it up over the shoulder. If the patient has telemetry, a big box, or even if they're hooked up to a machine, pull the wires tight down front. All right. I tried my best to make it, you know, because all the wires are coming in, you know, from up here. So I tried my best to make it where, you know, putting it on the shoulder was better. It never worked out that way. So telemetry, straight down front, any kind of NG tubes or anything like that up over the shoulder. All right. So the specifics on the shoulders, you know, you rotate the shoulders, put the hands on the hip, rotate the shoulders, and it removes the shadow of the scapula as much as it can be. It's still going to be there, just not quite so much. So it also removes the soft tissues of the arm so that, you know, that doesn't get in the way. If you have a patient, and demographics here are usually older patients where the skin gets a little loose, right? You can't grasp that. You will one day. So if the patient's just standing there like this and they, you know, they got extra skin from, you know, whenever they were younger and maybe bigger, then it can cover up a portion of the outer portion of the lung and look a little bit like a pneumothorax. Okay, so hands on the hips, rotate the shoulders, removes that, but also rotates the shoulders, the scapula out of the way, at least a little bit. So consider patient type. So as far as your collimated field goes, the image receptor size is pretty much a square. You may work with a rectangular one that you may have to swap out the orientation of it, but hypersthenic, you're going to have a broader, shorter lung, so broader, shorter collimated field. Elderly patients, you know, they tend to not have as much lung volume anymore, especially if, you know, they've gained weight over the years. Scoliosis, make sure that you've got, if you've got a patient with obvious scoliosis, make sure you've got light field on both sides of the body on the image receptor. That's going to give you probably more image receptor direct exposure than what you would be comfortable with. And then, patients on oxygen, make sure you get the oxygen tube out of the way. Don't stand them up if they seem unstable, if they're on oxygen and they are just kind of seem weak, just don't stand them up. The first code, and I put that in parentheses or in quotations, first code I ever had was not really a code. I mean, it technically was, but it wasn't. The guy his heart never really truly stopped. It just got real thready. So what happened was that I was a first semester student, and I was working with my clinical instructor on this chest x-ray because I was a brand new student. This was probably within a couple of weeks of the lateral thing. And we had this patient, and they ordered chest x-ray on him, and so transporters went up and got the patient, brought him down, and we didn't read the chart. I don't even know if they brought the chart. Had no idea why he was there, but we were doing a C-spine on him. Okay, so C-spine, you're not really thinking of things like, anything had to do with the chest, right? You just think the guy's got a sore neck. So we're doing a C-spine on him, and this was back when we used films, and Jane, clinical instructor, went to run the films and left me in the room with the patient. He got real still, but he was making noises. And so, okay, this is an old movie. It's a Stephen King movie called The Shining. Okay, so some of y'all have seen that. Jack Nicholson at the end of it when he's frozen is like that. This guy looked like that. So I get down in front of him and I say, "You okay?" Okay. I was like, "You're not okay," So I shout out, and of course they, thank God that the nurse and Jane came in and they did CPR on him. His heart never stopped, and they never even had to give him rescue breaths. They just put him on the floor and gave him a couple of pumps, and his pulse came back up. He was admitted the day before for low blood pressure. They sent him down in a wheelchair. I'm sorry. They sent him down for a C-spine in a wheelchair. Okay, that was a failure all the way across the board. Nurse should have never let him leave the department. He fell down, and that's why we were doing a C-spine on him. He wasn't in a collar, right? So he had been clinically sort of diagnosed as not having a neck fracture, right? Sent him down in a wheelchair, and he had a history of his blood pressure dropping to a point where he passed out and fell down. And that's exactly what happened in the x-ray department, okay? So go all that way, to kind of bring it back to patients on oxygen. Assess your patient, familiarize yourself with their condition, if at all possible. If you have access to the chart, if you have a patient who's on oxygen, it may be better not to do a PA, maybe an AP, leave them in the chair and do an AP. Sometimes you can do a lateral in the chair as well, right? If they're on a stretcher, maybe don't stand them up. Do the AP on a stretcher. Make sure you annotate that it was AP. And then, do your lateral at the wall bucky on the stretcher, something like that, right? So assess your patient was the moral of that long drawn-out story. So that's your positioning, and what you want to see then on a PA chest x-ray is you want to see 10 posterior ribs. Now, going back to last semester, or last year, first semester, how do you differentiate posterior from anterior ribs? What does the anterior rib not touch? Somebody?
The spine.
Okay, the spine, but specifically the sternum. What does the posterior rib always touch? The spine, right. So if it's hitting the spine, you got posterior rib, right? So your anterior rib stops right there. So your anterior ribs are at an angle. Posterior ribs are relatively horizontal. So that's how you're going to count them. 1 and 2 are on top of each other. We've got 1, 2, 3. Notice where the clavicles are in relationship to the third rib. 3, 4. Notice where the fourth rib is in relationship to the aortic arch. 5, 6, 7, 8, 9, and then we've got a portion at 10. So good chest x-ray. So what we're going to look for on a chest x-ray is absence of rotation, and we're going to look at the ends of the clavicle as they relate to the spine, and that's going to determine our rotation, right? We're going to look for the clavicles to be around T3, T4. We're going to look, and that's going to determine lordosis versus kyphosis. Can you grab the door? Yeah. Can I finish this slide and then I'll hand it over to you? Yeah.
I wanted to be invisible.
So where the clavicles, and I'm sorry, I'm not Amy. She pulled up sick. You probably got an email from her. Yeah. Okay. So where the clavicles look like they're intersecting the spine is going to determine lordosis versus kyphosis. We do a lordotic chest x-ray, where do the clavicles go? Up, right. So if we have a patient who's presenting lordotic, or your image presents lordotic, that means that maybe the patient was laying back, you were doing an AP, you did an angle to the sternum, clavicles are too high, right? If you have a kyphotic patient, that's going to dip the clavicles lower and closer to the aortic arch. So it should be around T3, 4, okay? So that's that evaluation. So rotation, rotation, one side of the, you're going to get separation between the spine and the clavicle on one side and superimposition on the other side, right? So you want to see top to bottom, so apex to costophrenic angles without rotation, and your clavicles around T4, T3, T4, okay? No lower than T4, all right?